All right, gang, talking about IV and meds. This is part 4 of the series, and this is when we're talking about actual IVs and IV accesses in different parts of the IV and in blood sampling, and again, interosseous infusions. We're going to break this up a little bit for the lecture of this, though. The fastest way to get something circulated around somebody's body is via the intravenous route. Okay. It is the bread and butter of kind of what we do. Okay. It allows us to insert medicines. It allows us to put in fluids to and body and blood replacements. It allows us to give medications and then again, obtain venous samples so that we can study those to see what was wrong with the patient. So again, biggest thing is the common sites, the arm, the leg, the neck. But the biggest thing is here is you want to get something that's patent, something that's open. And again, by the way, in a patient who is low on fluid, hypovolemic patients, if they've been throwing up a bunch, if they have been sweating a whole bunch, remember that the pipes aren't going to be filled up all the way, and that makes our job a little bit harder because it's really harder to get circulatory access when those veins are flat. So again, that's one of the challenges about IV access, and the good news is that we have a lot of ways in which to do this. Okay, now central venous access, that's what it usually goes deep within the body. Really hard to collapse those guys, but again, they require a little bit more technique, and we don't do them at the paramedic level. Critical care level, we do this, but we usually don't. The internal subclavian femorals, those are all considered central lines. Okay. So the external jugular, by the way, is considered a peripheral IV, but a lot of places, it kind of depends on protocol, will or will not let you start them. Me personally, I am a huge fan of external jugulars because it's usually with a little bit of training and technique, they're actually really easy to hit. Again, and the central IVs are placed kind of near the heart. That's where the medicine all dump, or the fluid areas dump out, and it's used for long-term use. However, they're not without their problems, and the biggest one is it's kind of a direct line to the heart, aka direct line for infection to get in. Versus a peripheral, by the way, in a PICC line, you guys might hear a peripherally inserted central catheter. Everybody's like scared of these things. No, they're put in at the hospital. They're threaded in. And the biggest thing is they're both the central lines and the peripherally inserted lines are filled with an anticoagulant. So if you're going to use these lines, again, you got to make sure that you pull all of the anticoagulant out. Usually 50 cc's of blood is what we do. It kind of depends on what it is that they're pulling out. Usually if you pull out 50 milliliters of fluid, you're going to get all that anticoagulant out. So the things that you're going to need, again, you got to have your solution, whether it be, and there's several solutions, lactated ringers, normal saline. Normal saline is kind of our bread and butter one. They've got all different kinds of flavors of that. The normal saline, 1/2 normal saline, and we'll talk about that more when we get into medicines. Okay. We can also we got to have there's other things that we can put through these IVs, which of course is colloid solutions. These guys have osmotic properties that help attract water, but they also require a lot of refrigeration or other preparations, which makes it really bad for EMS use in the field as a standard thing. Maybe your critical care units might have it, but most of the time we don't. Now, the other thing is, the crystalloids is what we usually use, and it's usually some sort of isotonic. The only one of the hypotonics that we carry is 5% dextrose in water. Again, and remember, that's not the same, water does not have the same pH as your body's normal, the salt content. When we say normal saline, that's 0.9 of normal saline. So again, your crystalloids are lactated ringers, normal saline. The hypotonic solution is usually your D5W, D10. Okay. So again, and the thing is about having these solutions is that actually they help to keep the vein open. If we have a running IV, and by the way, make sure that they're room temperature or going into the patient at a closer to temperature that the patient is. You really don't want to use for the 3 days here in Florida where it gets cold, but you really don't want to have 50-degree fluids going into a 98.6-degree patient. You're probably going to end up with more problems. You're gonna cause their body temperature to drop. And again, in some cases, that's kind of a good thing. Most of the time, not. It should never, ever, ever be warm. The only time I think that we could use warm fluids is if you're warming somebody up from it that's in a hypothermic state. Blood, again, this is the most desirable thing to put back into a patient in which they are bleeding. But again, remember that normal saline lactated ringers, guys, does not carry oxygen, where blood cells, red blood cells, do carry oxygen. So if we're going to replace it, we really want to replace it with blood if we have it. Problem is we usually don't have blood in the field, okay? There's a lot of problems with having blood in the field. You have to keep it refrigerated. It has to be changed out. And not that it's not a great thing to have, but by the way, in the field, we only use usually O-negative blood where you can give it to anybody. It saves us from the ability of typing and cross-matching the blood. Again, if certain people have antibodies that prevent it, the A or B antibody, or heaven forbid they got both, the blood type is kind of extremely important. And again, usually we don't have the ability to test for this out in the field. And remember that there should, by the way, be a label for these. It should say what it is. There should be some sort of medication administration port. And then we got the medication administration, the set that we use. And there's two types of sets that we have. Is a 10. Well, actually, there's a lot more of them. But the drop factor in the two big ones for us is 10 drops per milliliter and 60 drops per milliliter. Let me explain what I mean by that. So a micro drip set usually is 60 drops per milliliter. Very controlled. It allows us to control, especially like if it's in a medication. It's what we usually use as a micro drip set so that we can easily control the medication administration. Macro drips allows us to deliver large volumes of fluid. What I mean by those two things, micro drip, by the way, every drop is really small. It takes 60 of those drops to make 1 milliliter of fluid. Okay. The macro drip is either usually a 10 or a 15, and you need to take a look at what the set says. I've seen some 20s out there as well. But basically what that's saying is it takes 10 drops of fluid in order to make 1 milliliter going into the body. Okay. Make sure that you know that with a drip set. We did play with that in lab a little bit, where I hooked up a micro drip and a macro drip set and showed you how fast that they flowed. Again, control, I'm using a micro drip. I want to give a lot of fluid, I'm using the macro drip. All right. So the different parts of the bag, again, you're spiking the bag. This is the administration, the drip chamber spike. Again, we usually squeeze this to where the fluid fills up to there. And when I'm squeezing that, I usually clamp this line off. I usually will clamp it here at this point. Usually I just pinch the line, fill the chamber, then turn it back upside down, and then allow the fluid to run out through. This is your flow regulator stopcock. Again, and this is for drug report. Usually the bag themselves, this one usually has a drug port right here, but some of them actually have it right there on the bag. It's a rubber stopper. Be careful with those guys, because one of the problems is you put it through the stopper, but then you put it through the other side of the bag. Oops. That's a no-go. By the way, the Porter drug infusion, you can have 2, 3, maybe even 4 of these depending on what set that you have, okay? Unfortunately, there are some sets out there which have none, and that kind of makes things, that's like a day without sunshine, basically. You should have at least one port in order to give medications or attach another IV through it. Extension tubing is usually it's to extend the original macro drip or micro drip setup. Again, that's just it's kind of like an extension cord at the house. Okay, and then you might have pump tubing, which allows you to attach it directly to a pump, and then you got your volume sets to deliver a specific volume, or Buretrol sets is another name for those. Let's go ahead and keep going here. Y tubing is, again, when you have 2 administration ports, one for blood and then again one for a normal saline solution. Usually your blood products have to be filtered, and they usually, by the way, they come in a special set of blood tubing that has the filters already installed in it. so that basically, remember that if the blood starts to coagulate, you don't want to put those clots into the patient. Straight blood tubing usually only has one reservoir. I have never actually seen one of those. So, matter of fact, we usually give normal saline when we're giving blood, only because that it also helps prevent some other reactions as well. You kind of want to dilute the blood as you're putting it in. And by the way, the notion that a paramedic cannot monitor blood product administration. We can't actually hang it. We can't actually start it as a standard paramedic, but yes, you can monitor it. What they fear is that they're going to have a reaction, an allergic reaction, and if they do, Benadryl is usually your weapon of choice, or your medication of choice to counteract it. Okay, so don't be afraid about if they've already hung the blood. All you got to do is, when the blood stops, is start a new is detach it and attach a flowing fluid, normal saline, or put an extension set on it, and after you flush it out. Now, the actual equipment that you're going to use to do this, again, is your IV start, and the cannula. Again, and there's several types of needles, and this is the one we commonly use. It's the catheter is over the needle, okay? And we've already done this. We stick the needle in there. We get a flash. We know that we're in the right spot. We advance the catheter into the vein. That's our standard. 22s are usually used for your fragile veins or just medicine administration. 20 and 18 are usually, again, medication. Usually you can use a 20 actually to do fluid replacement. It's not a big deal there. 18, 16, and 14, though, yeah, we've talked about these guys. The green Goliath, the silver sword, and the bronze dagger, okay? And, of course, I think you guys know my stance on this. If they're going to need fluids, this is the gold standard. If not, this guy and this guy works just fairly much as good. The constricting band, again, that's the rubber flat band that we apply in order to help to dilate the veins. Again, we constrict venous return. We're not constricting the arterial. That way our veins engorge, okay? So we play, again, when we start the IV, hopefully we've all done this already. But again, put the constricting band on, concentric circles, clean the site. I kind of like not only cleaning the site, but I like to use iodine if it's all possible and they're not allergic to it. Again, insert the catheter in. Again, usually 30 degrees is kind of where my thing is. Draw a blood sample if you need to. Once you draw the blood sample, pop tourniquet. And how to troubleshoot, by the way. Make sure, again, if you should be able to pull back and get blood out of an IV, okay? If you're not, I would severely doubt the patency of that line. Again, you're going to connect your IV tubing and then push the fluids in to see if you're in the right spot. Every now and then you are going to be sitting next to a valve, which won't allow you to draw blood, which is kind of a pain in the neck. But the point of that is that, I can pretty much guarantee you if you're in a patent line with a 20 gauge, you're going to be able to draw blood out of it. It's a pretty much given. I'd say 98% of them you're able to do that with. But you got to make sure that, again, you got to make sure you're in the right spot and make sure to flush this line out. Again, turn on your IV and check for the flow. And again, they're putting by the way, a lot of systems I've worked in actually use this particular setup. It's a beautiful thing. My only problem with this one is that, it actually puts it over this and that. So you've got to take the whole dressing off. That's why when we were talking about when we started an IV, putting the Tegaderm just strictly over the site area. It's kind of, and then make sure that you want to label your bag of who started it, when you started it, how you started it. Especially for a field, you really want to make sure, and especially if you added something to it, you definitely want to put some sort of labeling on there so that they know where this came from. All right. So again, your IV tubing stuff, again, make sure that you, I'll make sure I'm not going over. Oh, no, we got two more. So connect your IV tubing, open it up, make sure it flows good, then drop it back to maybe 1 drop a second. That's your keep vein open rate. Even if it's a 60 drop set or a 10 drop set, doesn't matter. 1 drop a second is just fine. Okay. Now, we're going to pick back up on this one on our next video, because this is going to be the fun stuff. We're talking about starting different peripheral IVs. All right, guys. Oh, speaking of that, by the way, a lot of us, we use the hands. If they're younger people, babies, children, yes, you can use the feet. Pretty much if it's a vein, you can use it. Make sure that it's going towards the heart is where you're starting it. But usually the reason that we don't use feet is because there's a lot of germs down there. And again, we want to make sure if you do use a foot vein, you want to make sure that you definitely clean that site extremely well. I've started IVs in kind of some weird places before, but again, we try not to do that unless we absolutely have to. Okay, and like all of our other choices are used up. All right, we'll talk about some more on the next video, guys.